it now?
Mm-hmm.
Okay. I'm going to have Joel set up for a pancreatoduodenectomy. Okay, so that being the case, Allison, what is it?
Removing the pancreas, gallbladder, and something else.
Not exactly. Wetner, do you know what that is?
Say that again.
Pancreatoduodenectomy.
Part of it. Duodenum.
Oh, the pancreas is
Good
the
news.
Okay, where do you think the defect is, Randy? Hmm? Nobody, where's the defect? Where do you think?
I think in the duodenum, aren't they gonna reposition it to the pancreas?
Well, it's in the head of the pancreas, and remember the pancreas has a duct. Do you remember what that duct is called? That's one of the names, and then it also has a name, duct of Wirsung, and it empties into the duodenum at the same area that the common bile duct. And do you remember what that area is called? The ampulla of Otter. There's a sphincter called the sphincter of Oddi that controls, so the pancreatic juices, enzymes, empty into the duodenum or duodenum, as does the bile from the common bile duct. And so this would be a case that would be an open abdominal laparotomy procedure. The patient is usually very, very ill, and they suspect that there's cancer, of course, and that the cancer maybe has metastasized to other organs. There's another name for this procedure. It's been named a Whipple, W-H-I-P-P-L-E. Oftentimes when patients need this done, they're pretty gravely ill with cancer, and sometimes we'll go in and we actually open them up to see how far the cancer has spread or metastasized. And sometimes there's nothing that we can do for them. We'll close them right back up. So it involves some of the biliary system. It might involve part of the common bile duct. Cancer might be all in that same area there. So we're going to have to go in and remove the cancerous area, the head of the pancreas, part of the duodenum, and reanastomose. And so that being the case, let's talk about what type of anesthesia would you expect this patient to have, Sylvia?
Local anesthesia?
Oh.
Wait, no, I'm sorry. I wasn't general.
General, right. There's no way they're going to
No, I don't know.
Okay, so general anesthesia. So they're going to be put to sleep. And what position, Michelle, would you expect them to be in? Supine, right. Wetner, where would we prep? Okay, what are our parameters? Where to where?
Bedline to bedline, nipple to pubis.
Nipples to pubis, bedline to bedline. And Jeremy, what do you think? What kind of prep solution?
Betadine.
Well, we could use betadine solution,
Or Duraprep.
or Duraprep, or Chloroprep. We could use alcohol too with an Ioban. We have a lot of options. Probably most likely today you're going to see Duraprep or Chloroprep being used. And remember with Duraprep and Chloroprep, with Duraprep they couldn't be allergic to seafood because of the iodine in it. We are not prepping mucous membranes, so we can use Duraprep because it doesn't have alcohol. Or I mean, it has alcohol in it, but it's not mucous membranes. We could use Chloroprep. And so we have a number of options that we could use. But we would prep nipples to pubis, bedline to bedline. Allison, what would our drape be?
Just abdominal drape.
Okay, what does that comprise of?
For just draping out?
Yeah.
4 towels, and then just the drape afterwards?
So 4 towels, with or without perforating towel clips, a lap drape, Or we could use the utility drapes that have the peel and stick, or we could use a U2 system, 2U drapes, where we make our own fenestration. So it'll say on the card it's position preference. You may or may not use an IOBAN. All right, so we have our position, we have our prep, we have our drape. As far as medications go, Randy, you think that we, as not anesthesia, but our surge tech team, would be given any meds in this case?
Probably like an irrigation or, like antibiotics.
Right, that would be what I would say. If anything, those would probably be the two things that we would give. Now, if we were thinking about this, let's say this was an abdominal aortic aneurysm repair. What I'm trying to get at is the instrumentation and the equipment to get in the laparotomy approach is the same. That doesn't change. You still need a lot of the same equipment. You still need light handles. You still need suction. You still need longs and laps, and you still need gowns and gloves and such. But things, once you get into that abdominal cavity, dependent upon the type of case you do, the instrumentation and equipment you have and meds change. So if this were an aneurysm and we were going to take out a section of the aorta that was diseased, and we had to put in a synthetic graft, and we might have to then clamp distally and proximally, what sort of meds now are you thinking? What do you think, Kristen? Right, maybe heparin, anticoagulant, things like that. If we were doing a case that was local MAC, then we have to add that xylocaine piece. And whenever we add meds, we have to have a marking pen, and we have to have labels and a med cup. Or if it was in our irrigation ANSEF, like you said, we would have to label the graduate picture. So you see, a lot of our cases use the same equipment and supplies, but what changes is things like instrumentation and equipment. So Joel, you're setting this up. What would make this case different than a vascular case? What would make it different than a abdominal hysterectomy case? Because you still need Kellys, you still need copers, you still need knife handles.
Right, you need all that stuff. I would think with all the vessels and the ducts that we're going to want clip pliers and a lot of things like that, we may want what's already been said, I guess irrigation, possibly with antibiotic with ANSEF or something like that. Depending on what it is, it could be possibly cancerous or something, some type of infection. We may want something to put the specimen in, some type of cups, things like that.
Right, but from an instrumentation standpoint, you still need suture scissors. You still need Kellys and Carmelts and Cokers. So because if we're doing an abdominal hysterectomy, we're still going down through all those layers. And we still need the Cokers to put the rectus muscle back together and such. But what makes this case different than, say, a vascular case?
Well, if we're cutting into the ball, we're going to need clean instruments and dirty instruments.
Right, that changes it. So if you used a knife on the intestines, on the bowel at all, you would need to not use that knife again. But how about clamps? You now want to be looking at bowel clamps, things like that. If we were doing an aneurysm, we want things like our DeBakey's and Cooley's and Satinskys, and we want vascular things. So if we were doing a hysterectomy, now we're going down the Haney world, and Rogers and Mastersons and clamps that are used in GYN surgery, some of which you haven't seen in the aesthetics that I just named. So that's what's going to change.
Like Babcock's.
Babcock's to grab, right. Probably right angles. Vessel loops, maybe clip pliers, maybe some Kittners for this kind of case. Okay, now this is a big case. This is a huge case. We're going to be doing a lot of manipulating, a lot of working in the abdominal cavity, peritoneum. What did we talk about that in these kind of cases where we're doing a lot of manipulating, what might we need towards the end of the case then?
You might want to,
Pardon?
You might want it local.
No, probably not local in this case, because they're going to be in the hospital for several days. Well, we might want to have them on hand.
you might want to put in a drain.
Yes, A drain, excellent. Most likely we would. So then that means our suture changes too, because we need a drain stitch, right? All right, now let's talk about the suture that we would want for this case. What kind of suture do we need, Emily?
For the drain or for like so?
Well, the whole thing. How many stitches? What kind of stitches? What would we use them on?
When you sew up the skin at the end, you want that on it.
Okay, well, let's just say we need a skin stitch. Or if we don't use a skin stitch, what can we use on the skin? Right, one of the two. So that's one stitch we need. And what size do we usually use on the skin? Probably like a 3/0. And that's physician preference, what kind? Okay, what kind of needle tip? Skin. What goes on skin?
Cutting.
Excellent. Cutting, right. So we need a cutting needle. Okay, we got skin. Then we got sub-Q we gotta close. So we need a stitch for sub-Q. Then we have our muscle, right? And our fascia. Probably like a O. We have our peritoneum. All right? Now, we said drain. We gotta have that drain stitch, probably like a 685, a silk. Or a nylon, one of the two. So that's 6 stitches. Now, as we go down into the peritoneal cavity, do we run the risk of running into some bleeding?
Yeah.
Yeah.
How are we gonna control it?
Suction.
Pottery.
Cautery,
Might be-
tie, so you know you need free ties and you're also gonna need stick ties. Now, in this day and age, we have a lot of staple sets that we use, but sometimes we do have to hand sew or do an anastomosis of bowel and such. So we would probably need a taper needle and maybe some silk for that. So we have all those stitches. So don't forget, just because you think of the layers, you have the bleeding that could occur, so you need ties and stick ties that are swedged on needles. You need a stitch for a drain, and you need stitches for anastomosis. So besides all your layer stitches, right? Okay, and this person's going to be on the operating room table for a really long time, probably. A catheter. We better put in a Foley catheter, because if we're going to be hanging IV solutions for 2 or 3 or 4 or 5 hours, we want to know what's going to come out. So a catheter would be a good idea. What else would we maybe worry about with blood clots? Or what else would we want? I'm sorry.
Like pads.
Teds.
TEDs or SCD stockings on. Right. Okay. So, that's pretty good. I think that you've thought of a lot of things. How about dressings? We didn't talk dressings.
Non-adherent.
Maybe steri strips, Telfa, or just regular dressings. If the patient is very obese, we might want in a binder, something like that. Okay, so with that said, do you see what I'm saying about different cases? You still get in the abdominal cavity the same, you get out the same, but what you do once you're in there changes things with meds and clamps, and whether you need vessel loops or not, whether you need staples or not. If this was an abscess, you should be thinking of a culture, and you should be thinking then of maybe antibiotics after the culture. And if you're going to do a culture, what are you putting it in? Is it fluid? Is it tissue?
Sterile.
Cultures have to go sterile. So, all those things you need to think about. So your preference cards may or may not be perfect. They might not tell you all that information. It would be wonderful if they did, but if they don't, you have to be thinking about the stuff that you need for this case. So Joel, how many tables do you think you want?
Big case, I'm gonna use all my tables, I think.
Okay, right. And let's just do that for today anyway. It would be more common to put your Mayo stand actually between here, but you can leave it there.
Okay.
Now, in this scenario, we're taping this so you can see this. Truly, the room would be set up like this, but Joel would be facing the other way. And so just for purposes of filming, we're going to have him do it this way. Another thing is we would need a custom pack that would be something more of a major pack, And so all we have is an arthroscopy. So Joel's gonna have to improvise and make do with that. Now, I'll be his RN and I'm gonna be the doctor too, I'm a jack of all, I guess. With that said, I would have checked for holes in my package, checked for expiration date, and this table I would wanna make sure would be dry. And now I'm gonna open this pack up, and Joel can help me because he hasn't scrubbed in yet. So Joel can grab this. And this is your gown, and this is some prep. So we're gonna put this over here. We already opened a gown for Joel. So actually, this has to go this way. So this is gonna be like this. Don't turn your back to that. So grab that and pull down. Okay. Now, I could open up another gown for you, or I could open this gown that came in the pack on the table, but because it's already open, I'm just gonna open this on this table for him. Oh, lost the, it's all right. Okay, so with that said, we're gonna have Joel go out. He's going to scrub in using the waterless scrub. And Joel, I have to tell you, I think that the Avogard is getting pretty skimpy almost.
Okay.
So come on out and tape them, and we're gonna start timing them. All right. 2:55, so you have till 3:05. So you would roll up your sleeves to 2 inches above. You would have safety glasses on and a mask. And so go ahead. So, Michelle, give them 15 minutes on the clock, okay?
Candy, won't it be till 3:10?
Yeah, didn't I say that?
3:05.
Okay, and you would not touch your shirt, you know that.
Right, yeah.
Okay.
Doing that 2 inches above.
Because this morning we were doing it, and the person that did it this morning touched their shirt, and I said I would have had to fail them if they
Oh,
really
okay.
did it.
Yeah,
So
no, I would never touch
I
my
would
shirt.
suggest that you wear a short sleeve shirt when you come to test. All right,
Back on over there.
okay. Now, this,
That probably would be
that would not be a
gloves on.
good thing. All right.
Okay, my Avogarded. So I don't need this. I'm also gonna check, you know, maybe for any water spots or anything like that on that. Make sure it looks good. Thank you.
Did you flip your gloves on your table or no? Where did you find?
I think they're right here.
Very careful. This is a little big for me, but it'll work.
Joel, I'm gonna open up your Belfour on this table.
Okay. And right now I'm thinking about, you know, how many people are gonna be in here. Do I need any gowns? Obviously a surgeon's gown. This is a big case, probably a PA or another doctor. Students. All that stuff.
So your surgeon's gloves. I'm standing here because I'm waiting to turn.
Yeah, that's not,
Okay.
didn't touch my cuff at
Right,
all, but I
so
think
pull it
just
up. You're okay. No, step up to it, you know.
switched all my stuff around when I wasn't looking. Alright, so I'm gonna get rid of this.
You can leave it.
Okay. I'll leave it, okay, so let's go on here. I have the tree, some of this stuff. Mix this in.
Other way. Okay. Yeah,
Let's,
no,
right hand?
is it? Okay.
Left.
Allison, pull it down for him from underneath, will you?
If I had some free ties, which I'm definitely gonna have, and put those down right now. Yeah.
Take them out.
Two to me, three to the tree.
Open them up. There. And you're gonna wanna take that foil off.
I'm gonna have a lot of instruments, so I'm probably gonna I don't see, I'll have to look a little better, but I'm still thinking of, cautery at this point. I'm gonna need light handles, thinking about the irrigation that I'm going to need.
I'm guessing you got a bunch of that stuff in your custom hat.
So I'm gonna get down to that. I'll save that just in case the night comes in. I have this, I have those.
Okay, you probably wanna take this so you can get this table.
Okay. Yes. This one. Just carefully come over
Okay,
here.
we look for an indicator, go ahead and take that.
Indicator, it's not wet or anything. So pieces. Over here.
Now, you would not want that to touch the wall, I should say, but we're kinda close quarters here, so
Okay.
do your best, but you would not want that to touch them.
Yeah, I feel like this is. I don't like this at all. Ooh, nice light handles. I was hoping for them. This is a little different than normal. Okay, but here's what I'm gonna have to do. Switching up my routine here. I'm gonna have to just make this work, and this is killing my time. So, this is just gonna make myself a little room. Nothing's hanging or touching anything like that. Discard that. I'm gonna come over here. It's the filter on the top changed.
Yep, and
everything.
the indicators on the
It's,
outside were changed.
Okay, and that's upside down, I can't see it,
Okay.
but it
Yep.
looks good. Okay, I'm gonna grab this. How's that filter doing?
I'll check this filter, I'll look at it, looks good.
Okay. Way over. I'll lift this up. Oh, they're all disconnected. That's good, I was hoping for that. Better get my stapler that I need. Very carefully. Thank you. Put this right here. Okay, I wanted to. Thank you. Suture, you're gonna have tons of sutures, so just keeps coming. drape. So. Nice. Okay. I got another one. So is this one extremity drape?
Don't give me the stuff you don't need on that path.
Okay, extremity drape, don't need that. I do need that one, however, I don't need this. To keep these towels are always good. Duodenum or pancreas might put
Yeah.
something in there.
Good idea.
Don't want this one, though. This is a towel, I'm new, that might be something I need to learn about. I'm gonna put all my discard that now, it's contaminated. Garbage. Okay, this is really quick. In the shuffle.
Do you have the towels for your drape? Might not have. No. You got it. Okay.
Thanks.
Yeah.
Okay, you are missing a lot of things.
I need
So I would have to
irrigation.
open up that, I'd have to open up this, I'd have to open that,
Lots.
about 4 packs of laps, that, and you're missing a cotter.
I did mention that though, at some point, just so, that's on the record. Yeah, so. Okay.
So I would have to flip all of this stuff.
Cautery, light handles.
Now, if you'd used a major pack, we'd have everything we need.
Stuff everywhere. Scissors can stay there, this can stay there, and we use that.
Okay, you have 10 minutes.
Okay. Okay, there's a blade on that scalpel. Okay, so I suppose at this time, if it's okay with you, I would get count.
Okay?
Um,
You'd have handed me your sheet, and I would say security call clips.
1, 2, 3, 4, 5, which seems
Okay,
peculiar to
yep, my card says 4, but I'll write down 5.
me. Okay.
For printing toe clips?
1, 2, 3, 4.
Okay, Kurt Kelly's.
1, 2, 3.
Then that's a tonsil. Okay.
1,
Straight Kelly's,
1, 2.
Cokers.
1,
What'd you miss
2.
first? Go back. No, what's underneath there, under your caramel?
Wait.
You have one more instrument. Go that way.
These this way?
Yep, right there.
Okay, right here.
Okay, so 3. 3
Okay.
straight Kellys.
Okay, 1, 2, 3.
Caramels,
1, 2, 3, 4.
Cokers,
1, 2, 3, 4.
Alice's,
1, 2.
Babcock's,
1, 2.
Leahy's,
1, 2.
Tonsil,
1,
Long Alice's,
1, 2.
Long Coker.
1.
Curved Doyens, 1. 2 straight Doyens,
2.
sponge ring holder,
1 short and 1 long.
okay. Needle holders,
1, 2.
knife handles,
2 short and 1 long.
okay.
Open
Tissue forceps,
1, 2, 3, 4, 5, 6, 7.
okay. Retractors,
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13.
yeah, you know, I
and
might have to have
14.
you do that again.
Go for it. This one?
Yeah,
Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13.
Okay, and we have to count the bell for all the pieces to the bell for.
Oh, 3 pieces to the belt for.
No, there's a lot
Unless
more.
there's-
9 nuts, all of that.
Oh, okay, so
Okay, so
1,
1, 2, 3, and then the rod would be 4, 5, 6, those pieces if they came apart. So there's like 7 to 9 pieces to the bell phone.
Okay.
Okay, and we added some clipper pliers. So,
Yep, I have 2 longs.
2 long clipper pliers, I'll add that to the sheet,
Okay.
okay?
We could also do electric cautery tip.
Are you ready for that now?
Might as well, yeah. I don't know. Well, unless it's not on here, I guess it's been on here.
No, okay, if you wanna do it now. 1, cautery tip,
If we did.
No,
possible
we don't do
policy,
full.
no? Okay.
Kittners,
Well,
so you've got laps to count, you got longs.
yeah,
So
there's
you
all
probably
stuff
wanna
in
pull
here.
all of that out first,
Yeah.
cause your blades would be in there and all of that.
Okay.
Kittners for this procedure.
Mhm.
But, cramp for space here, I think, probably. Depending on what I needed to do. I don't want that right away.
Now, are you gonna have meds? Probably not, so why not stick that up in your mail stand right now?
What?
Your skin scribe or your pen, your marking pen,
Oh, okay,
okay?
absolutely.
All right, now you wanna count?
Yeah,
Sponges?
this wouldn't have anything, so.
All right,
We could do, so my laps are kinda hanging out, there'd be 5, so
Okay.
I'd break it, I'd show you
okay,
the.
1, 2, 3, 4, 5,
break it.
break it. 1, 2, 3, 4, 5.
It's 10.
Okay, so I'm gonna mark that down as you have laps, you have 10, what do you have for longs?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
10 longs, okay, how many Kittners?
1, 2, 3,
I
4,
need to see them.
5.
1, 2, 3, 4, 5. Suture booties, how many do you have? Hold them up, let me see them. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Suture booties, cautery tip. Do you have a scratch pad or hypo?
I do have a hypodermic needle that I'm probably not gonna. Oh no, this is just a empty.
Okay, so you don't have any.
Empty. Mhm.
Okay.
Probably would ask for a scratch pad.
How about blades?
1.
Okay,
I definitely need more blades.
okay.
And then the one that's on there already that probably would be on there.
There's an, and that was in your set like that?
Mm-hmm.
Oh, guys, we cannot do that. All right, let's count our needles.
1.
Those are ties, okay? So you have 1 needle,
Definitely get some more of those.
2 blades, no hypos. You have, Kittners,
Mm-hmm.
5, and you have suture boots, 10. All right.
And then at this point, if I need irrigation, especially with anything,
Yep.
I would get that from you. And
I'll get you some, I think it's over here.
if I could make labels up, but not necessarily put them on yet.
All right.
Just to make
I
sure it
got
was.
sailing,
Okay. 0.9% sodium chloride.
October 2015. You wanna hand me that, turn that a little bit for me? Sailing, October 2015,
Okay.
500 mils.
500 milliliters.
Okay, you labeled that, all right.
Calibrations. Put it on here. At this point, I would put a blade on my.
Okay, put the one up that has it on there.
Okay. Definitely gonna need some shorts and a long. I need that. Can I do my my Babcocks? Thinking of the instruments that I need.
Need that?
Probably not.
Okay,
It's like
what do you need that you don't have? As to where you're at right now. Before you finish anything that you're setting up,
Mhm.
what are you missing? You have it looks to me like you have two mets here, right? So you have a baby and I couldn't touch this, but a baby and a regular. Do you really think you need the baby?
Probably
No.
not.
Okay, you have a regular, but what do you think you need?
Maybe like a male.
Oh,
big one,
you need a
accessories.
male and you need a long
Some
met. So you'd want that. Okay, so go to your tissue forceps.
instruments, okay. There's some answers, I'm gonna just get there with teeth. So I should have some without teeth, short, maybe, I don't know, I'm new, I put it up there, definitely have a long one. Gonna need another very long one. There's teeth, put it that way. Okay.
Okay, in this case, the Adsons with teeth probably will not be used till towards the end of the case on skin. So you're gonna have a lot of stuff up, so I would put that back. So, but the point is, more things you wanna tell me you need. So, let's keep going.
Okay. Probably don't need mosquitoes for this. I'm gonna put these up here. I put a whole bunch of these because it's
Okay, clamp
that
on that.
type of case. So we need that. We'll need caramel. So I always need cokers.
Okay, you'd put your caramels up. And you'd probably have 6 or 8 Kellys.
Tons. Lots of
A
them.
lot, probably at least 4 caramels, probably 4 cokers. Babcocks, do you want Leahy's?
No.
No, I don't think you need Leahy's.
I want these straight and curved.
Mhm. What?
This I would put.
Oh. Okay, so you're over your time,
Mhm.
because I threw you for a loop a little bit and gave you a lot of stuff.
Mhm.
And that is what the real world will be like. You will get a lot of things. You're all used to practicing with the same custom pack and you switch a few things, but not a lot. We did a lot of things different here. I opened things on different tables, I totally changed things, and that probably threw it off
Yeah.
a little bit. What you had planned, I just threw a monkey wrench in.
Mhm.
And that's a daily occurrence in surgery. They're gonna put stuff, the good RNs will know where to put things and won't put a gown on a table that's not gonna house your gowns, but they're not all like that. Some of them don't even think about that. And they'll bury things that you have to find. A couple of things I'd say to you is your plan changed the minute I changed it for you. So you have to be adaptable. The other thing is you kind of got crowded, and then that's when you got a little messed up here. I would have not counted my sponges, blades, needles, all of that until I got organized. Because what should happen is your blade should come in a foil pack in probably that ring stand. I mean, that's one way. I could have given them to you as an RN, but because of that, you kind of needed to dig through that first and get organized before you count it, I would say. So let's keep going at this point. You're over on your time, so you're going to need to speed up a little bit with that. This you want to bury. These are not X-ray detectable, so I would have put those under there. And let's do the gowning, gloving, and let's go through that. We would bring the patient in the room now. We were going to do that. Do you want to go through all of that, how that would work? Well, I can bring her in and we can, that's all. It'll be more real. Okay. So I'd bring the patient in and I'd say, Mrs. Hanson, this is Joel here. Joel's going to be helping Dr. Lenz today. And Joel, if we were this crowded, she's probably going to turn over and say, oh, hello, maybe not. You want to look at her.
Okay.
Is she 500 pounds or is she 10 pounds soaking wet? I mean, that's pretty extreme, but that's important to you. Because then you're going to want to tell me, now I'm going to have Allison lower that side rail because I cannot get this bed in here and butt it up without the side rail down. Now I want to make sure that my bed was locked and it was in the right position. I'm going to butt up both beds and I'll have you pull your tables back. And we'll pretend that I'm not contaminating his tables in any way.
For testing purposes, are tables gonna be in the right position on the wall? Or are we
Well, I'm gonna try to have them the way we need to have them, but. Now, you wanna make sure that all the arms are in, they're not getting pinched. IVs didn't get pinched, and we'll pretend that this is on her. And now if she can move on to the other bed, we would say, Mrs. Hanson, do you think that you could move on over to this other bed here? And if she says, oh, sure, great. If she says not, then this is when we want to get lifting help and get a slider board or roller board. And then we would have her go to the other bed. And so we'll pretend that she can move herself, Caitlin, and Kristen, help me get that over there. And we would move her IV over to the bed. And now, somebody needs to stay with her while I bring this out. Or, if there isn't anybody else, which there might not be, anesthesia needs to stay with the patient, I'm going to move this stretcher out some. And before I bring it out, I'm going to put a safety strap over her legs and make sure that her arms aren't dangling or anything. I can come back and fix things after that. Okay? So I'm going to make sure that if she had a catheter, that it was hanging right, that her arms aren't hanging, her IV's okay, and all of that. Okay, now, this is the time that your RN needs to be with the patient. I need to make sure that my lights, of course, aren't way out of whack, that my pottery machine is plugged in and ready to go. I should have done that ahead of time, my suction, everything. Joel gets to fiddle around a little bit. He's still got time to organize and do everything. And so we would have wanted him to have his meds by now, so he doesn't have to ask for them when I should be taking care of the patient. He wants to be able to label his saline or his sterile water and have counted. Because now he can do the final touches while I'm over here. Maybe he wants to separate these out. Maybe he wanted to keep them folded, whatever. He's got some time to do this. Now we know she's going to be supine, right? And so right now anesthesia is going to do what? This is pre-induction. Right before we induce her, what is anesthesia doing?
Putting on vital signs.
Okay, so they're going to be putting the EKG pads on. So Mrs. Hanson, I've got some cold pads that are going to monitor your heart. You're going to feel me sticking them on your chest and your side. Mrs. Hanson, I have a blood pressure cuff I'm going to put on you. Da-da-da-da-da, okay? And then they're going to put the oxygen saturation on her finger. And the one thing that your RN would do also is that when she came in, I would say to her, now, Mrs. Hanson, I know who you are, but I need to verify your name, so could you state your name for me, please? And she says it. Could you state your birth date? Now, do you have any allergies? Oh, no, dear. Okay, I need to verify the procedure. I know what we're doing today, Mrs. Hanson, but we have to verify this for safety reasons. So what do you understand the procedure to be? And so then she'll probably say, oh, they think that I have cancer in my pancreas. Or she would never say they're doing a pancreato blah, blah, blah. She'll never know it that way. So if she can tell me that we might be removing part of my pancreas and part of my intestines, then I know that she knows. Now, are you warm enough, Mrs. Hanson? Okay, so now your anesthetist is called the anesthesiologist. And they've looked at the EKG, they have a good oxygen saturation, their IV is running and it's good size. Sometimes we have to change it right now in the OR. The IV that they had from the nursing unit or whatever isn't adequate. We might need to put in another IV. And so then I call on the phone my anesthesiologist, and my anesthesiologist comes in. And so Nicole, my anesthesiologist, comes walking in and says, hi, Mrs. Hanson, I'm Dr. Nicole. I'm here to put you to sleep today. We talked about your anesthesia and such, and so do you have any last questions for us before we put you to sleep? Oh, no. Okay, pick out a good dream. Now, we're doing general anesthesia. So, how'd you do, Nicole? So we're doing general anesthesia. So we're going to give her something like Diprivan or Propofol, a narcotic analgesic like fentanyl, muscle relaxant, maybe a Nectine or Zemuron or something, right? And then, when we give these drugs, she's gonna go off to sleep. We're gonna say, Mrs. Hanson, can you hear me? Can you hear me? We'll close her eyes, put some tape over her eyelids so she doesn't have a corneal abrasion. Now I'm gonna put the endotracheal tube in with the laryngoscope. Then I'm gonna tape it down, and you as the anesthesiologist are gonna listen to her lungs to make sure the tube is in the right spot. Now I'm gonna turn on my inhalation agent and gas, right? And she's asleep, and your RN would have made sure that your RN is here in the building before we would have done any of that. And now it's time to prep Mrs. Hanson. So we're gonna pull up her gown, we're gonna get her arms out if we want them out, and secure them on gel pads. Make sure that if I had to put a Foley in, now would be the time after she's asleep that I put the Foley in. She'd need SCDs on, we'd have those on, and I would prep nipples to pubis, bedline to bedline. And so now she's all prepped, she's positioned, the bed is locked, the safety strap's on, everything's great. Here comes Doctor. Hi,
Hello.
Joel.
Hi.
I hear you're my surge tech student.
Yeah, did you, after
I used Avatar.
Okay.
Sorry, I don't need it.
So I might just tuck that away.
So how far along are you in your training?
Oh, this is my first day.
Oh, great. I suppose you have that wonderful instructor, Candy Meldy. All right. And then my other RN comes in to save the day.
What hand do you like me to go first?
Okay, I like my right, it's on my card.
Yeah.
Now, this would not be a good area to do this in, because we are way too close quarters, so we would have to spread things out. All right. So we'll drape. And then you can back up so you're not all.
You like to do the left hand?
Right, give them all in.
All at once.
Okay, don't wait for me, go back. Now, your doctor's not moving sides, I'll tell you that. Don't go over the bed.
For the fenestration, the head's up this way, yonder.
Okay, we got it wrong, but that's all right. And that might happen. Once it's put on wrong, there's nothing you can do. You just can either work with it or you have to take the whole thing off. Now, the problem with it being wrong is we don't have an arm thing on that side now. That's okay, we're just gonna have to get another sheet or whatever. We would not get another drape if we didn't have to.
Oh, you can use that stockinette you had. Oh.
And I have to look to see which side my cautery's on.
Mhm.
And my suction, it looks like suction's over there. So, do you want me to actually break this?
No, you don't have to. But then you're gonna throw this off, and then I'm right-handed, so hand the knife. Time out, and then this is when your time would stop. So, 15 minutes, that does not include me asking a few questions about your case, what you're setting up, quizzing you a little bit. And then, when it's over, if you have failed anything, we'll go over what you failed. what you can do to improve upon it. If you didn't, then that's great, I hope you passed. Your aseptic technique was pretty good. When you came around the bed and went to do that, we're a little crowded. I expect that you know you cannot go over the bed or anything. So if for some reason you are shoved because of this room being small, you better tell me then, because I don't know that you know if you don't tell me that I would have to move this and I can't go over the bed and whatever. So do your best in the confines of this room. It is a little small.
He went over the bed with the drape.
With the lap drape, he was really close to the bed, and then when he came up here with his towels, he was really close. Other than that, I thought your aseptic technique was good with your setup. I thought you were kind of organized, except for when you, when I started throwing stuff at you, you got a little bit, it threw your plan off. So, and that's gonna happen in surgery. That's why you have a plan, and then you go with, you adapt to change. That's what surgery is all about.